So let's move into talking about some of the specific injuries we want to be able to identify and treat. The number one killer on the battlefield is hemorrhage, arterial injury to an extremity that causes death from rapid blood loss. This is the primary thing that we want to be able to identify and rapidly treat to modify the death rate from wounds. So again, the number one cause of preventable death on the battlefield is extremity hemorrhage. What we're going to do is this. We're going to learn how to identify arterial and serious bleeding and what that constitutes. We're going to learn how to self-apply and buddy apply tourniquets. We're going to learn how to pack wounds and how to apply pressure dressings. And finally, we're going to spend a little time discussing individual first aid kits, or IFAKs. This image has some important information that I want to emphasize. A lot of us were taught the ABCs early in our EMS or medical training, which it stood for airway, breathing, circulation, everything you're supposed to do. The rest of your life is supposed to follow the order of the ABCs. Even as a surgeon, when you go through advanced trauma life support, if you don't start by evaluating the airway, you fail. Well, this is completely different in the tactical environment. And this is an example how we have to take some of the knowledge you already have, and we don't need to discard it, but we need to reorient it to what we're doing in a tactical situation. The care under fire phase, our number one priority is to remain a combatant. Our first goal is to achieve fire superiority with superior use of our weapon systems and superior application of our tactics. We're going to encourage the casualty to remain engaged in the fight, if at all possible, and to render self-aid if he is able. We're only going to provide the most critical aid because we're still under direct fire. That is, if there is an arterial injury to an extremity, the casualty is going to self-apply his tourniquet, or once we've gained fire superiority and we can retrieve the casualty, the only treatment that we're going to institute at the time is to rapidly apply a tourniquet over the combatant's clothes, and then we're going to get him to cover immediately. Until we've achieved that, nothing else can happen. So, for care under fire, our new ABCs are this. Number one, we're going to assess the tactical situation and the condition of the casualty. Number two, if there is significant arterial bleeding, we're going to control it by providing a tourniquet. Number three, we're going to get the casualty to cover. Then, when we are under cover and in a more permissible environment, we can think about applying some of the concepts from the tactical field care phase. Now we can put our medic hat on and we can use our old ABCs and evaluate him from head to toe for other life-threatening injuries. Evaluate his airway, evaluate his breathing, evaluate his circulation, look for disability and other injuries. This is the difference between civilian trauma, our old ABCs, and tactical medicine and our new ABCs. When we do reach the casualty, we're going to provide a very rapid assessment. We're going to use our hands, we're going to use our eyes. We're going to touch, we're going to feel, we're going to look for that life-threatening bleeding. We're going to do that rapidly. We can do it while we're kneeling, we can do it from the prone, but we have to do it. If we don't find any life-threatening bleeding, it's time to get the casualty to cover. If he has an arterial injury, we're going to use the casualty's tourniquet, we're going to apply it rapidly, then we are going to seek cover. When we're in an environment where we can do so, it's helpful to check a radial pulse. Why? The palpable pulses on your body are an indication of your blood pressure. We don't need to go into a lot of detail about this, but essentially it's important to know that if you have a carotid pulse, by definition, you must have a systolic blood pressure of at least 60. If you have a brachial pulse on the inside of your arm, pretty much the same for a femoral pulse, you have to have a systolic blood pressure of at least 70. The radial pulse, which is the pulse of the small artery that runs directly along this bone called the radius on the soft side of your wrist, at the crease of the wrist, the one that the nurse always feels when she's checking your pulse. If you have that pulse, you must have, by definition, a blood pressure of at least 80. This is important because if somebody has a radial pulse, the chances that they are in shock is very slim. The adult body contains about 7% body weight blood volume. What that means is for an 80-kilogram male, you should have about 5 liters of circulating blood volume. Why is this information about how much normal blood volume a person has? And how is this information about a pulse important to us? Well, death comes from excessive exsanguination. What does that mean? You lose too much blood, you die. The primary way that that's going to happen is from an arterial injury. We're going to spend a little bit of time on this, but here's foreshadowing to what I am telling you. You can lose a significant amount of blood before you go into shock. You can lose a lot of blood before you show any signs and symptoms of being in shock. You can lose a significant volume of blood and effectively remain in the fight. This is knowledge that you need. This is knowledge that you need to impart to a casualty to help him remain in the fight. Here's the scenario. You've got the casualty under cover. You've applied a tourniquet. By your impression, the casualty has lost a huge amount of blood. You have the casualty sitting up. He's talking to you. He's breathing at a reasonable rate. You can reach down and feel that radial pulse. It doesn't matter how much blood you think he's lost. He is telling you by the things that you're seeing and finding that he is not in shock. This is important knowledge. I want you to understand that young, healthy adults and other fit operators will compensate for a long period of time before they start to show signs and symptoms that they are going into shock. One of the take-home points is this, that if you have a casualty who you suspect has sustained significant blood loss and they are unconscious and they don't have a radial pulse, this is a sign of impending doom, and you have to do something. I want to be able to make the concept of circulating blood volume stick with you, and I don't know any better way to do that than by a good visual. For a 180-pound man, which 180 pounds translates into about 80 kilograms, we've said that 7% of body weight is roughly your circulating blood volume. So for that 180-pound, roughly 80-kilogram guy, he has a little over 5 liters of blood. Shock occurs primarily from blood loss, and this is the primary form of shock that we're concerned about as combat lifesavers. Every drop of blood that we can help the casualty keep is important to him. This is why the soonest that we identify an arterial injury to an extremity, that having the casualty self-apply a tourniquet, you applying it to yourself, or applying it to your buddy who's in need is vital, because that is the injury that we can most modify to reduce that die-to-wound statistic on the battlefield. So let's take a look at this. 5 liters of blood. What happens when we start to lose some of that blood? The first stage that we talk about in blood loss involves that class 1 hemorrhage, where somebody's lost up to about 750 cc's of blood. What we understand is losing up to that much blood in a healthy male generally does not produce any significant change in their vital signs. They might have a little elevated heart rate. Likely, they're not going to be breathing harder. Certainly, there's no significant change in their blood pressure. What does it look like when somebody has lost 500 to 750 cc's of blood? Why don't we take a look? So one of the things that we talked about is that with a class 1 hemorrhage, which is anywhere from about 500 to 750 cc's of blood loss, though it looks like an incredible amount of blood, it does not produce significant effects as far as your compensation goes. There's not really any change in your blood pressure. A person might have a little bit of elevated heart rate. Your respirations probably aren't going to go up either. But what does that actually look like? That's a pretty good approximation of about what 500 cc's of blood looks like if it's just poured out on the ground. If you see that coming out of you, that looks like a tanker truck's worth of blood, doesn't it? The reality is, you are still in the fight with this much blood loss, and you are still in the fight easily. We want to use this knowledge to make ourselves mentally tough, and we also want to use this knowledge to help keep others in the fight. It's not to say that you're a wuss if you've gotten shot and you've had significant blood loss and you're a little bit anxious. That is absolutely normal. But the point is, this is not enough blood loss to keep you out of the fight. It's about the same amount of blood loss that you would experience if you donated blood. And what's the treatment for that? You get some cookies and some lemonade. So again, the interesting thing about losing 500 to 750 cc's of blood is it doesn't produce any significant change in a person's vital sign. And again, that's part of being mentally tough, knowing that you can lose that much blood, but you can still stay in the fight. What happens when somebody's lost more than a liter of blood? When somebody's lost 1,000 milliliters or a little bit more of blood, this is when they start to show some of those detectable signs and symptoms of shock. Definitely, we expect them to be breathing a little faster. The compensatory mechanisms of your body want to get more oxygen into the blood that you have. Your heart rate goes up. It starts beating faster because you want to supply more blood to all the vital organs. Likely as well, the person will be experiencing a little bit of anxiety. They're generally in pain from their injury, and starting to get about this much blood loss is going to make a detectable difference. When somebody's lost 1,500 to 2,000 milliliters of blood, this becomes a very critical time. When you've lost up to 2 liters of blood, shock is present and death is imminent. This is when somebody's blood pressure drops precipitously. That means fast, and it drops a lot. Their heart rate goes way up. This is when people have that classic rapid, weak, faint pulse. This is when somebody from the stress of shock doesn't waste oxygen talking to you. They're very pale. There is every appearance that they are in extreme distress. Once again, the take-home point is this. By the time somebody is displaying full-blown signs and symptoms of shock from blood loss, They are in a state of extremis and death is imminent. You need to get that person blood. They need to be seen by a surgeon. All of these things have to occur to save their life. Up to that point, we're likely going to be very successful in any resuscitation measure, expanding their volume with fluids, giving them blood. All of those things are likely going to produce an instantaneous improvement in their state of shock and prevent them from worsening. Again, the take-home point, there's a critical threshold, especially in healthy people, where they will deteriorate rapidly on you, where somebody will go from being relatively stable, potentially comfortable, breathing well, and in no distress, to when they've reached 2,000 milliliters of blood loss and more, where they can rapidly degenerate into a state where they cannot maintain life. It is our job to prevent shock and save that life. So we've gotten an idea in a very visual way how much blood we generally carry inside us as circulating volume and what that looks like when we lose some of that blood. We break hemorrhages down into different classes based on their severity and how much blood a person has lost. This is again part of the take-home point. A class 1 hemorrhage where somebody has lost up to 750 cc's of blood, they generally show no significant signs whatsoever of a change in their status. They may have a slightly elevated heart rate. They may show minimal anxiety, which could also be because they're wounded, but as a whole, their compensatory mechanisms are so effective that even with that massive amount of blood on the ground, if we've stopped them from bleeding further, they're unlikely to go into shock. As we go further into severity of hemorrhage, people start to develop more and more signs and symptoms of shock. Shock is a terminal event. By the time somebody is displaying the signs and symptoms of shock, their blood pressure is dropped and they can't maintain consciousness. They're breathing extremely rapidly. They have a faint or non-palpable pulse. They are in what we call extremis. That person needs a surgeon now. They need whole blood products now, or they are going to die very quickly. If you remember nothing else, this is the point that I want you to remember. Healthy, fit adults do not show signs and symptoms of shock until they are almost at the terminal stage, meaning they are almost dead. This happens after somebody has lost 1,500 to 2,000 cc's of blood. They will compensate very well for that amount of blood loss until they reach a critical threshold where they can't maintain life. This can happen extremely rapidly, and this is what you have to appreciate. As a result, control of hemorrhage is our #1 priority to save lives on the battlefield. What constitutes major arterial bleeding? This is very easy to demonstrate. What you're looking at is a wound induced on live tissue. This is an animal. The day we do all of our training on rubber dummies is the day we have the best cared for rubber dummies in the entire world. What you're seeing is a femoral injury. This is what arterial bleeding looks like. It is bright, it is red, it is forceful, it is pulsatile. This is what, if you see it, you are going to react immediately by applying the casualty's tourniquet to the extremity above the injury. And this is what we're going to now talk about, how we self-apply and buddy apply tourniquets. A few general principles about tourniquets. Number one, we want to place the tourniquet at least 2 finger breadths or approximately 2 inches above the site of bleeding. Next, we're going to place the tourniquet directly over the casualty's clothes. We're not going to take time to expose the wound. We're going to apply the tourniquet over their clothes. We don't place tourniquets over joints, meaning over the elbow or over the knee. Why? 2 reasons. One is the tourniquet is less likely to be effective. Joints are bony, particularly the knee, and you can't get enough compression around the bone to compress the artery. The way the tourniquet works is this. You're circumferentially squeezing and constricting the compartment that is the lower or the upper extremity. As you're squeezing the muscles, you are also squeezing down the artery that runs along the long bone, for instance, the femur or the humerus. This is how you're stopping the bleeding. You have to apply the tourniquet tight enough to occlude that artery to stop the bleeding. You can't apply a tourniquet over a joint because, number one, the bony anatomy will prevent you from being able to tighten the tourniquet effectively to stop the bleeding. Number two is you are more likely to damage the nerve that runs with the artery at the level of the joint. Part of the fallacy that tourniquets cause harm is the idea that wherever you place a tourniquet, you're injuring the extremity at that level, and the person's just automatically going to lose their limb at the level where you've applied the tourniquet. I never use the word guarantee as a doctor. That being said, I guarantee you that this morning, in virtually every operating room in the country, that a surgeon has applied a tourniquet to a limb and then has performed an elective procedure on that limb. We are not in the habit of hacking off good limbs from elective surgery. We're in the habit of helping people. Surgeons have been using tourniquets for that purpose for decades before I was even on the scene. Let me make this point and make it clear. Tourniquets are not harmful. Studies done during the global war on terror have also demonstrated the fact that in battlefield medicine, that we can't document that somebody has lost a limb as a result of a tourniquet being applied. So let's drown that kitten in the river forever and get past the point of believing that tourniquets are harmful. One of the ways that we prevent them from being harmful is applying them properly. One of the ways that we avoid doing injury by applying a tourniquet is applying it correctly. If you apply it over bony anatomy like a joint, you're more likely to compress the nerve against bone. Nerves, as opposed to arteries, will not tolerate being compressed for long periods of time. And essentially, wherever a nerve dies, that's where I start the amputation. If you're applying the tourniquet properly over the meaty compartment of the extremity, tourniquets left on for less than 2 hours rarely have any side effect whatsoever. Surgically, we apply a tourniquet, we leave it on for about an hour, we decompress the tourniquet, we inspect where we're working for any bleeding. If we need to work longer, we inflate the tourniquet again and go about our business. If the first tourniquet is not effective at stopping the bleeding, apply a second tourniquet directly above the first tourniquet. Do not remove the first tourniquet. Tourniquets hurt. They cause pain. There's no way for a tourniquet to be effective that does not cause pain. One of the things that we can overcome with training is helping everybody understand that the tourniquet is supposed to hurt, but it has to stay on because it is saving the person's life. We want to make a note of the time when we apply the tourniquet, either on the tourniquet or on the patient's forehead with a Sharpie, so that who's ever receiving that patient knows what time the tourniquet went on. That is basic and important information. There are multiple types of tourniquets. We're going to talk about them, and let's demonstrate some of the more popular. I'd like to introduce a close friend and colleague, Mike Griffin of Austere Provisions, tactical EMS provider and trainer extraordinaire. Mike, thanks for being with us, man.
Thank you. Happy to be here.
Let's talk about tourniquets themselves. There's several types of tourniquets. I think these probably represent the three major types of tourniquets that we see today. The TK4, the CAT or the Combat Application Tourniquet, and the Soft T. Every one of them has their pluses and minuses. Some of them have applications that work better in some circumstances, and because the mission drives the gear, some tourniquets may be more appropriate for what you do than another. By far, the CAT, the Combat Application Tourniquet, has become the most common tourniquet out there. It's not without flaws, it's not without faults, but it works extremely well. The major point is, I don't care which tourniquet you use. One is not decidedly superior to another. What is important is that you have a tourniquet and you know how to use it. By far, the most common tourniquet currently is the Combat Application Tourniquet. While it certainly has its pluses and its minuses, all tourniquet application contains the same basic principles. Identify the source of bleeding. Go about 2 finger breadths or 2 inches above the perceived site of bleeding. Apply the tourniquet. Those that operate by a windlass mechanism, and I'm going to demonstrate that, crank it down until you reach your end point. What is the end point? You have stopped the bright red pulsatile bleeding. If you fail to do so, and you're certain that you've applied the tourniquet in the best way possible, the recommendation is apply a second tourniquet above the first tourniquet. Don't remove the first tourniquet. Arteries are viscoelastic. It is entirely possible that the artery can retract higher into the limb than where the entrance wound is, and what you're seeing does not accurately reflect the level of where the injury has occurred to the artery. So if your first tourniquet is ineffective for any reason, the recommendation is apply a second tourniquet above the first tourniquet.